Yeah, hello. Thank you, Julio, for having this again. So I think we last met in Dallas 4 years ago, and it's good that we are face to face together in our days. So wait for my presentation. I will move to a totally other topic to treat pathogenicity factors of bugs, and I will show you Staph aureus hemolysin as an example with small molecules designed to counteract the hemolysin effect. Oh, yeah. Before I start, I have to explain, no, the first slide, please, again. I have to explain a little bit how funding works in Germany. I can go back. Okay. How funding works in Germany, because it's different from what you see in your country and what you see in the US. So we have two levels of funding. We have academic research, which in Germany is in the responsibility of the federal republics, and it's funded by a federal republic. So in my hometown in Hanover is Federal Republic of Lower Saxony. In Martin's hometown, it's Berlin Federal Republic. But then we have a second line, which is the so-called non-academic research centers. We have different ones, and you may have heard the names. It's Helmholtz, it's Max Planck, it's the Leibniz community, and it's Fraunhofer. And these are funded by the German government. So not on a federal basis, but on a governmental basis. And normally, for a very long time, these lines had not been connected very well. In 2011, the German government started a project which is called the German Centers of Lung Research, trying to bring data from basic research into translation and to the bedside. And one of the centers of the German health centers was the Center of Infectious Disease, and one was the German Center of Lung Research. So I'm in the board of the German Center of Lung Research, but I also part of the German Center of Infectious Disease. And what I show you now is a collaboration between these centers of research. And mainly it's a collaboration between the Helmholtz Center of Infectious Disease in Braunschweig, which is focused on drug development, first on a basic research basis, but then with the goal to come into translational medicine. And the academic center, Hanover Medical School, is responsible for the translation to the bedside. So this is a scenario. And as you can see in the next slide, this is a collaboration group. And I only want to mention three of the people. Mark Brönstrup is the biochemistry guy on Helmholtz, who is responsible for the development of small molecules, and he does it together with Rolf Müller, who is specialized in drug development, also as part of Helmholtz Center. He's based in Saarbrücken. Thomas Hesterkamp moved into Helmholtz Center from the industry. He had been for a very long time responsible for setting up clinical studies for pharmaceutical companies. And he is responsible for the translational unit in the Helmholtz Center. And I, as the head of the Department of Respiratory Medicine, Infectious Disease, I am responsible for figuring out the trials. So this is how we collaborate. Always the question is gram-positive infection still a threat? we can controversially discuss this. In my mind, it is still a threat, because if you look to severe community-acquired pneumonia, 80% is caused by gram-positive agents, mainly strep pneumonia and Staph aureus. We also can controversially discuss whether there is bacterial infection without viral infection. I'm not so sure. So I think you need the viral trigger for epithelial damage, and then there is a co-infection with gram-positive agents. However, if you look to the association or correlation between influenza and Staph aureus, and I published a review paper some years ago, there is a very strong relationship in incidence, but also in morbidity and mortality. And Staph aureus pneumonia in the influenza times is responsible for a high burden of disease. If you look to the resistance patterns of these bugs, they are multi-sensible. This is not the problem. It's not MRSA pneumonia. It's mainly susceptible Staph aureus. And you can treat it with most of the antibiotics we use as standard treatment all over the world. Nevertheless, even there's no resistance, there's high mortality. And the reason is the pathogenicity of the bug. You know, for strep pneumonia, it's pneumolysine. For Staph aureus, there are several pathogenicity factors which make it very dangerous. And one of this is hemolysin. I will show you what hemolysin does in a minute. It disintegrates endothelial and epithelial barrier because it destroys tight junctions. It's cell-lytic. It increases inflammatory parameters. So a lot of different modes of action which make the bug more pathogenic. And therefore, there is a look to counteract hemolysin. There are two, I will show it in a minute. There are two compounds by two different companies which had been studied in the past, but these are antibodies, complicated to produce, not easy to produce them in a high number, and very expensive. And the approach Helmholtz and Hanover are working on is small molecules, because it's easy to produce big amounts and it's cheap. And so we started a program together with a lead investigator in Germany to find such kinds of small molecules to counteract hemolysin. So again, what is hemolysin doing? It's secreted by Staph aureus as a monomering 33 kilodalton protein, oligomers to heptamers on the host cell membrane and form pores and destroy the normal function of the cell. And these are some of the virulence factors. It induces cell death at lytic concentrations, kill immune cells and compromise the host defense response. It causes alterations of cell signaling at sublytic concentrations and therefore increases inflammation and exacerbation of inflammation. It impairs endothelial and epithelial integrity by tight junction destruction, and it potentiates co-infection by all these mechanisms I talked about. So there is a lot of mainly murine experiments in which hemolysin has been inhibited, has been blocked, and it's well shown in the murine experiments that if you block hemolysin, you improve survival and reduce mortality and morbidity in the animal experiment. And as I had said, there are two compounds, one an antibody produced by Medimmune, which is now an AstraZeneca, part of AstraZeneca, Medimmune here in the US, and the other is Aridis, a middle-sized company, but these are not small molecules. They are in clinical studies. The first data of the proof of concept studies look very, very promising, demonstrating that if you use it preventive, that's one of the possibilities. You can reduce the number of severe Staph aureus infection in patients hospitalized, mainly in patients at risk when undergoing surgery for any case. And on the other hand side, if there is staphylococcal infection, you also can alter the course of the disease and the diversity of the disease. So we made a lead search, and I do not want to go in detail into what we did. And we found two components, and the most important one, the name is QDS, small molecules, which are able to produce in high amounts and which we used in first cellular and animal models. And what we did, I forget to say, all this from the beginning of the models on was financed by Carbix. Carbix is an American founder. There is a yearly, I think, funding symposium in Boston, and we were there in 2019, and we were qualified to get about $3.5 million of primary funding to do these experiments together with Carbix. And these are the first experiments demonstrating that we were able to reduce in different types of experiments the activity of hemolysin by responsible doses of these small molecule. We could reduce and inhibit cytotoxicity in primary human cells, also to different outreads. In these experiments, we were able to show that we reduce apoptosis and necrosis both by using this small molecule in infected cell experiments. And we were able to show that we could restore tight junctions after staphylococcal infection when using the antibody. So this small molecule did everything in cellular experiments we hoped it will done. And though we tried to understand why it is so effective, and the major point is that it interacts with these pores and remain the integrity of the pores which are normally destroyed by Staph aureus. So then we moved into animal models and looked infection models, whether it's effective. And as you can see, it's effective for the inflammatory parameters. There is, for example, a huge reduction in interleukin-6 and other pro-inflammatory parameters by using the QDS, a small molecule. And there is a dramatic reduction in the burden of Staph aureus in the lung end, because this is a bacteremic model in the circulation of the patient. So what are we doing now? So now we funded a company which is led by Mark Bernstrup Thomas Hesterkamp and myself, and we try to start first clinical studies. So we are waiting for the approval by the German regulators to start. Then first, as ever, we will start with a phase 1 in healthy volunteers to show that it is safe. But looking to the data we have out of the animal models, and we've run big toxicity models in animals, there's no doubt that it will be safe. And then we try to set up early phase 2 studies. And there are 2 ways to do so. And it's the same what have been done by the other companies. We can use it preventive. Patients who are colonized with Staph aureus when admitted to the hospital and undergo surgery. And we know there is a risk for Staph aureus infection in those who are colonized by about 4%. So it's something which can be used, and it's cheap. It can be used as a preventive measure. The disadvantage is you need big patient numbers to show that it is effective, and not the drug, but the study design itself is expensive. And the other one is to use it in Staph aureus pneumonia, which is possible with very small patient numbers. There is a mortality in Staph aureus pneumonia in ventilated patients by around 8 to 10%. So it's possible to show something with a remarkable patient number. However, you have to identify the patients early enough. And this in clinical practice is not so easy as it seems to be. But we will start, I think, with both of the studies. And the question is, what about the funding? And there, again, is a new possibility in my federal republic in Lower Saxony, where there is a new institute for new drug development. IBD is the name. And we admitted a proposal for 6 million funding days ago, and I hope we will be successful because this will allow to go to start. This is only an example what you can do with small molecules. And there are pathogenicity factors for a huge number of pathogens which could be addressed in the future. What we learned in this 5-year process now, since we have started, is it's possible to find small molecules. If you use a good platform, it's not a miracle. You identify molecules. There is established way to test that it is effective in cell cultures and also in animal models. And the main question for the future is, from which we get from the basic research, are we able to translate it into clinical practice? And this is where we are now. And with this, I thank you for your attention, and I'm open for your question.
Very good. We're just, it's going to be probably a lot of questions for you, but we're going to start making it around. Yes.
So it's a really nice presentation, Tobias. For me, it seems staph, there's at least 2 different syndromes. One is a very acute, overwhelming infection. People die within 24, 48 hours. The second is more of an airways infection in, your ventilated patients or your bronchiectasis patients. So I guess 2 questions around that. The first is, in that acute, nasty septic shock type patient, what's the window of opportunity? And that's, I guess that's my concern, is that animal models don't usually really assess the window of opportunity relative to patients. The second question is, what's the best route of administration? Because in the airways type infection, is it an inhaled route? Is it a systemic route? And have you thought through those things?
Yeah. So let me start with the second one. This is open. At the moment, it's IV and intravenous application. But I said in the beginning, we also have a very intensive collaboration with Fraunhofer, and Fraunhofer Hanover is focused on new inhalation techniques. So it's a small molecule, and there will be a number of possibilities to make it an inhaled drug. We have not started it, but it's possible. The first question is good question. Next question, because yes, the time difference always is a problem in animal models, and this we could be also too late in clinical practice. I think we need two strategies. We are not very good, that's my personal opinion, in identifying the patients with a severe course of disease. And we need, and this is something Martin is doing, and I think he will talk about it, we need better tools, and artificial intelligence may be one of the possibilities to identify the patients more early. And if this is the case, we can use it. With the preventive one, I was very cautious, but Bruno Francois' work with the MedImmune product shows that there is a remarkable proportion of the patients only colonized before surgical procedure suffer later on from a severe staphylococcal disease. So the preventive measure in my mind makes sense, and you can show that it makes sense. Martin.
Thank you very much. Along the same line, I think it's absolutely possible to inhale a small molecule, obviously, but the question is, do I reach the healthy lungs only, or do I also reach the flooded lungs where I want to reach the bug? But my question is another one.
Let me answer this. I think for the preventive part of the studies, inhaled may be very good.
Absolutely.
Because at this time you have no systemic part of the disease. For the disease itself, two possibilities: it's systemic and inhaled, or it's systemic only, and maybe to combine those may be most effective.
Yeah, you showed beautiful animal model data, but I think these animals were treated with the small molecule only and not with antibiotics. So I know you had it on your slides, but you did not go into the details. What is the effect on top of antibiotics? Because all our patients will obviously be treated with antibiotics.
So we used without antibiotics and with antibiotics. Well, if you use antibiotics, you reduce the mortality even in animal models, but there is still a mortality, and then there is an additional effect of the small molecule.
Thanks.
Nice work, Tobias. I have two questions, but I'll ask them one at a time. In your animal models, did you use clindamycin as one of the antibiotics to determine how much effect your molecule has on top of clindamycin toxin blocking activity?
Yeah, we used first generation cephalosporins and oxacillin. We did not use clindamycin. It's an interesting experiment we should do, because there is toxin binding by clindamycin. You're right.
Great. And the second question is, I think we see as much methicillin sensitive, actually should say just Staph aureus community-acquired pneumonia as ventilator-associated pneumonia. Why not study that population?
Yeah, this is a question of how to choose the best study design. And to be honest, even if it is more expensive, it's much easier to run a study for prevention, because the patient population is easier to define. For pneumonia, and mainly for nosocomial pneumonia, and I think we are all aware of this, the definition of pneumonia is the major problem. So is it pneumonia? Very hard to say in an intensive care patient. And then what is the responsible bug? And is what I find really the etiological agent? So finally, you have a much more heterogeneous patient population, And this is not
Yeah,
really
yeah, yeah.
ideal for such a kind of trials. So at the moment, it looks like we start with preventive.
And the mechanism, oh, there's a question.
Martin.
Probably you are aware of the study of CALO2, which was a compound capturing and bacterial toxins. And they did a trial published in Lancet ID on severe pneumococcal pneumonia within 24 hours of onset and bacteremia. So why not going with the compound for Staph aureus bacteremia?
Well, I'm part of the COL2 developing team. It's Combaxin. It's a startup from a company in Geneva. Yes, we published the primary data in Lancet Infectious Disease, but it's a very, very preliminary study. And this happened the first ed board was in 2018, and now it's 2023. And still a randomized control phase 2 study had not started. So there are a huge number of problems. I think to produce a compound, it's a liposomal based compound in high amounts. And well, COVID may have played a role, but yeah, it's a possible possibility. If you want to go on 2 tracks, preventive and as treatment, and the preventive track is Staph aureus colonization in the airways, we thought it's better to have the disease also an airway disease and not only a septic disease. That's the reason for this.